Okay, so we are at the final chapter. Um, but, but it's not really the final chapter in the textbook, but in the final topic that I told you we will cover. So this is the neurocognitive disorders. Alright, so this is the outline of the discussion. We are going to be talking about, of course, for the delirium, the clinical description and its statistics, treatment and prevention, also the major and mild neurocognitive disorders. We'll talk about the clinical descriptions and its statistics. The neurocognitive disorders due to the Alzheimer's disease, the vascular neurocognitive disorder, other medical conditions that can cause a neurocognitive disorder, substance or medication induced neurocognitive disorder, causes of neurocognitive disorder, and lastly, the treatment and prevention. Alright, so for an overview about neurocognitive disorders, so these are the disorders that affect learning, memory, and consciousness. So this is why usually with this type of disorder or when we see it, a lot of them would have lapses, particularly in the part of the memory, or sometimes it will be difficult for them to learn new things, like for example learning a new route, going to some place, as well as the consciousness itself, or being awake or alert in terms of perceiving and sensing things in their environment. And most of these disorders have developed or can develop later on in life. So usually we see this happening with people in the um, senior age, yung mga seniors natin. So most of them can develop these disorders. Okay, so there are several types of neurocognitive disorders, and these are clustered into the following. So the first one is delirium, wherein this is or it has the features of temporary confusion and disorientation. So usually people with delirium, they don't really have the sensorium intact in terms of where they are, what time is it, what day is it, and even the people around them, sometimes they don't know momentarily whom they were with or how they got there. So we will talk about those things later as we go on to these discussions. And then the mild or major neurocognitive disorder, this is a broad cognitive deterioration that affects multiple domains. So with this one is more on the cognitive abilities that is deteriorating, rather than the consciousness, and like with the delirium. And then we also have the amnestic, which refers to the problem of the memory that may occur in neurocognitive disorder. So basically this pertains to forgetting things, particularly the episodic memory. So that's usually the situation with these types of disorders. All right. So with as the DSM manual or the diagnostic statistical manual have evolved, so did the perspectives about certain mental health disorders. So like for this instance, from organic disorders, this particular group of disorders have become labeled as cognitive disorders instead, because of the fact that when we say organic, it means that the problem is really within the brain, but what they have seen in their studies or in the studies about neuro science is that it's not that the brain is deteriorating itself, or the part as or specific parts of the brain is are all deteriorating, but rather the interconnections of the neurons are the ones that is failing. So if you look about, or if you think about it, um, calling it as an organic mental disorder would be not apt, or it's not proper to call it as such. So from organic, it became a cognitive disorder. And also, aside from that explanation, the impairments cover more of the cognitive functioning. So this is why they have seen that it's more fit to call it as such than the organic term. This can also cause profound changes in the behavior and the personality. Though some of this may be considered to be a general medical condition, but then some of the symptoms itself are more or are better to be treated by mental health professionals than doctors. So let's move on to delirium. So with delirium, the central features of this one are impaired consciousness and cognition. So there's a problem with the awareness per se, and also of course the mental functioning. So this is something that develops rapidly over several hours or even days, and usually people with delirium have this appearance of confusion, disorientation, and inattention. You would also see them to have marked memory and language deficits. So like for example, you would be telling them, oh, let's go, you have an appointment with the doctor, and then the person would say, doctor, what doctor are you talking about? So that is more of the memory. The person is confused regarding the appointment, regarding seeing the doctor. So there is a confusion in that particular area. Now there are certain drugs such as ecstasy, molly, as well as bath salts, which can cause substance-induced delirium. So these things are very much concerning in such a way that, again, this type of disorder is something that can happen in the latter age. However, with people who have substance abuse disorder, they can have delirium even though they are not in that stage we're in, or in the age we're in, they are expected to have that. So with the facts and statistics, about 20% of adults in the acute care facilities had been affected or is affected with delirium. And this is more prevalent with certain population, particularly the older adults, again the senior ones, and also those who are undergoing medical procedures, which is basically expected, given that they need to consume a specific medication first before their specific procedures. Also, cancer patients and AIDS patients, likely due to the treatment or medications that they are also taking. Also, people in hospital or critical care are also seen to have some sort of delirium at some point. However, with the full recovery often occurs within several weeks. So this is not something that's lifelong. The client can go back to their normal state after several weeks. Okay, so what are the medical conditions related to delirium? So people with dementia, about 50% of the cases of them have involved temporary delirium, and this is this is quite expected, or this is often seen with them, especially when they forget things. Like, for example, they are walking and then suddenly they realize that they don't know where they are because of the dementia. So of course, delirium, the features of delirium will also be seen in that particular um, experience or situation. Also, with drug intoxication, poisons, as well as withdrawal from drugs are also seen in them. The same with infections, head injury, and several forms of brain trauma. Also, if you had sleep deprivation or immobility, as well as excessive stress, you can also experience this condition. So, although the prevalence is more on older adults, it's not it's not unheard of that people from other age group, even the young adults as well as the teenagers, can experience this particular disorder. Okay. Okay, now what is the treatment and prevention of delirium? So with treatment, of course, we have to first pay attention with the underlying cause, because it might be due to a certain medical condition, or it might be due to lack of sleep. Those things, of course, by experiencing that, or by seeing that, we are able, or we can see what proper type of treatment or intervention can be done in the situation. Okay, and also psychosocial interventions can be also given, like reassurance or comfort, because again, they are in a very confused state. So this is very important, the reassurance and comfort. It's not good to put them more in an agitated state. So the when the person experiences this one, make sure that they are pacified, or they are calmed down or pacified, in order for them to lessen their agitation. Aside from this, coping strategies should be practiced and discussed, as well as inclusion of patients in their treatment decisions. And then, of course, prevention. So, the proper medical care for illnesses, proper use, and adherence to therapeutic drugs are expected, especially if the cause of the delirium is due to substances. Okay, so for the major and the mild neurocognitive disorder, so the first up, we have the dementia, which is the gradual deterioration of the brain functioning. And aside from that, we also experience deterioration in judgment, as well as memory, as well as deterioration in language or advanced cognitive processes. Also, it has many causes, and it may be irreversible. So, with this particular condition, it's something that is that has a guarded prognosis, so to speak. Okay. Now, for the major neurocognitive disorder, this is the new term in the DSM-5 for dementia. Again, it changes as the edition change. So for this one, the term is now major neurocognitive disorder. So for the mild neurocognitive disorder, this is the new classification for the early stages of cognitive decline. So, with this one, it's not totally the cognitive functions is impaired. Some of it still remains intact. However, the person, although they are still functional, they have to be given some sort of accommodation in order to help them out to still continue living independently. So one of those things is to help them with use of reminders or lists. So those things. Okay, so for the major neurocognitive disorder, these are the DSM-5 criteria. So one or more cognitive deficits that represent a decrease from previous functioning. This should be substantiated by clinical assessment. So it means that it's not just observation, interview, and such. There should be also laboratory tests for this one in order to make the proper diagnosis for this disorder. So the decline, of course, or the deficit, of course, can interfere with daily independent activities. So like for example, they would forget that the stove is on. So those things, it can affect them, since if they are living alone, it would be difficult to leave them by themselves because of the certain things that they keep on forgetting. Okay, so prevalence and statistics. This is quite alarming because as according to the 2018 statistics, or the recent statistics as based on our book, there are new cases identified every 7 seconds. So throughout this discussion, there are already several cases that had been identified as a major neurocognitive disorder. So there is about 5% prevalence in adults from the age of 65 and up, and 20% prevalence in adults ages 85 and up. So about 5 million of people have been suffering from this kind of disorder. Okay, so estimating the number of those suffering from major neurocognitive disorders resulted to diverging numbers. So there is a dramatic rise in Alzheimer's predicted through 2050, and and this is because of the fact that more people are expected to live more than 85 years old. So that's why the prevalence is also going to go up, because more people are going to live more than that specific age. Okay, so what happens in the early stages of major neurocognitive disorder? So in the initial stages, we will be able to see or observe memory and visual spatial skills impairment. So they would have lapses in their memory. They will not be able to really understand their visual field anymore, or make decisions or judgments based on their visual field. because of this impairment. Aside from that, they can experience a facial agnosia, which is the inability to recognize familiar faces. So this is what I'm worried about, because I'm not in that age, and yet I really have a problem with recognizing faces. Aside from that, there are other symptoms such as delusions. There are cases like this. I had encountered one case wherein the client who already a senior citizen was claiming that the her family had plotted against her and put her in the mental institution. So there is this delusion. And then aside from that, apathy can also happen, so as depression, agitation, as well as aggression. There are people who are quite aggressive, older people who are quite aggressive because of this particular disorder. In the latter stage, or in the later stage, there is the continuing cognitive function deterioration. So it would be difficult for them. This is evident with the difficulty of doing basic things that would require, like for example, practical approach to problem solving. Like if, like for example, the door doesn't open, right? They would have difficulty figuring out how to do that. They would persist on doing the same thing over and over again, even though they have already seen that what they are doing is not working. And usually in that particular scenario, what we would do would be to when pull doesn't work, we would push the door, right? With them, sometimes they would fail on doing that because of the decline, because of the deterioration of their cognitive functioning. And with that one, in the latter stage, this is where and the support is very much needed, just for the person to be able to carry out their day-to-day activities. So this is why a lot of older people in the US are put in the home care facility, so that they would have someone to look after them, especially if they have this kind of disorder. So there is also an increased risk for early death due to inactivity or and onset of other illnesses. So because of the decline, the cognitive decline, some of them would rather just stay at home, because they don't want to experience the stress of being confused outside, of being lost outside, and those things. And of course, there is the factor of they are prone to other illnesses given their age. So these are the types of the major and mild neurocognitive disorders. So the first one is the due to Alzheimer's disease. So we're quite familiar with this one. The next is the frontotemporal. Okay. The next is the vascular. Next is the Lewy bodies. Next is due to traumatic brain injury. Another would be due to substance or medication induced. Another is HIV infection, prion disease, Parkinson's disease, Huntington's disease. Another would be due to another medical condition, and due to multiple etiologies, and the other one is unspecified. Now let's look at the neurocognitive disorder due to Alzheimer's disease. So nearly half of the statistics for the neurocognitive disorder is accounted for the Alzheimer's. So what are the clinical features of this disorder? So this is something that typically develops gradually and steadily. So it's not something that occurs insidiously. that would happen with just a snap of the finger, but rather you would see the deterioration progressively. Another is that the memory orientation, judgment, and reasoning deficits are seen. Additional symptoms may include agitation, confusion, or combativeness. They are quite aggressive. There are also sometimes people who will develop anxiety or depression. Okay, so what's the nature and progression of the disease? So there is what we call the nun study, which is an analysis of nuns' journal writing over many years that shows pattern of deterioration. So what they have seen in that analysis is that the early and the later stages of the disease is quite slow. It's only during the middle stages, when they are at the peak of the development of the disease, that it is rapid. The changes due to the symptoms are quite rapid. Now, for the post-diagnosis survival, the survival rate is up to 8 years. We can attribute that due to the slow deterioration pattern in the latter stages of the disorder. So the onset is usually something that happens during the 60s or the 70s. But we have what we call the early onset Alzheimer's, which happens from 40 years to 50 years old. Okay, so about 50% of the cases for cognitive disorder results from the Alzheimer's disease. Now, now for the prevalence, the disorder or the disease is seen to be more common with less educated individuals. However, more educated individuals decline more rapidly after the onset. Despite of the pattern that it's quite slow in the early onset, but they have seen that for people who has higher levels of education, they have a more decline, or the decline is more rapid after the onset of the disorder. Okay, so with these findings, it suggests that education simply provides a buffer period for a better initial coping. And this is seen to be slightly more common in women than in men. And this is possibly due to the loss of estrogen as women age, as estrogen is seen to maybe a protective factor for this disease. So this is why if you have seen the movie The Notebook, we were arguing, my classmates and I were arguing what did the older woman in the movie have. So some of them were saying, oh, she has dementia, while others were saying, no, she has Alzheimer's disease. So up until now, we're not really sure what the female lead has in the movie, because the older actors in the movie who portrayed Ali and Noah, they were not really given much screen time, except for when they were talking about the diary, or when the older version of Noah was reading the diary to the older version of Ali. So that's why we cannot make a proper conclusion out of the movie. Okay, so this is the graph of predicted Alzheimer's incidence. So if you would see the incidence is higher, it's very high, or it goes high as the years progresses. here for the 80 years old, 85 years old or older. And again, this is because of the number of the population and the mortality rate of people. We are expected to live around 70, 60 plus. So that's why the number is getting bigger as well. For those who are around the age of 65 to 74, we can see that there's really no that the predicted incidence is did not really change that much. It's just along this particular level. So what the 75 to 84 years old, the projected incidence is at this air is also same, almost similar with the 85 years old. However, it flattens by 2040 to 2050. Okay, so what is the range of the cognitive deficits of Alzheimer's? So some of them can develop aphasia, which is the difficulty with language. Some of them can also have apraxia, which is the impaired motor functioning. Agnosia, which is the failure to recognize objects, even though some of these objects are their own. There are also difficulties with planning, organizing, sequencing, abstracting information. So all of these things are all cognitive functions or all cognitive abilities that they are slowly beginning to lose. And then aside from that, there are also negative impact on social and occupational functioning, of course, because of these difficulties or these cognitive deficits that are experienced. Okay, however, the good thing about this one is that there is a new research that is focusing on the identity of the precursor of Alzheimer's in order to prevent the cognitive deterioration from further happening. Okay, so as you can see here, this is the PET scan of a person with Alzheimer's and a person without Alzheimer's. So we can see here that there is a significant decline in terms of the brain parts or brain activities. So with the normal brain, all of the parts or most of the parts, almost all of the parts are lighting up. So I'm not really sure what's being done here, but something that would definitely involve a lot of cognitive abilities or skills. However, let's say that the person is also exposed to that abilities and skills, we can see that not all of the areas are lighting up. Only this significant portion have lit up. The rest, although it's lighting up, it's not that it's not that it's not that energetic, so to speak. And also what we can see here is that there is some shrinkage in the mass, right? If you would see here, this is again the normal brain. There is definitely a shrinkage in the mass or the volume of the brain itself. Okay, now moving on to the vascular neurocognitive disorder. This is caused by a blockage or damage to the blood vessel, and this is the second leading cause of the neurocognitive disorder after Alzheimer's disease. So the onset is often sudden, just like with the stroke. So usually, people who would experience stroke, the bad type of stroke, would likely to have this type of neurocognitive disorder. So the patterns of impairment are it varies and most require a formal care in the later stages of life. So, what are the cognitive disturbances? They have identical features similar to dementia, and obvious neurological signs are the brain tissue damage. So there is about 1.5 prevalence in people 70 to 75 years old, and 15% of prevalence for people over 80 years old. So you can just see the jump from the statistics. From 1.5, it suddenly jumped to 15% as the person gets older. For this one, the risk is slightly higher with men than with women. So there is damage in the frontal or temporal regions of the brain, which affects the personality, the language, as well as the behavior of the person. So there are two types of impairment. This is already the frontotemporal neurocognitive disorder. I'm sorry. I thought we were still talking about vascular. Okay, so with this one, we can see the impairment and the decline in appropriate behavior, as well as the decline in language. So a good example of this one would be Pick's disease. Okay, now for the Pick's disease, this is a rare neurological condition which accounts for about 5% of all dementia diagnoses. So this produces cortical dementia similar to that of Alzheimer's. However, this can occur relatively early in a person's life, about or around their 40s to 50s. Unfortunately, little is known about what causes this disorder. But if you are very curious about this disorder, you can search NIMHS in order to read more literature about this one. Okay, so what about neurocognitive disorder due to traumatic brain injury? Now, for this one, the cause of this disorder are accidents. So the symptoms would last for about a week after the head injury, which can include the problems with executive function, learning, and memory. So for the most common symptom for this one is memory loss. And this can be found in athletes who experience repeated blows to the head, like for example football players or boxing athletes are also seen to have can also have this type of disorder. Now next is the Lewy bodies. These are microscopic protein deposits that damage the brain over time, and the symptoms happen gradually. It's not, again, same with Alzheimer's, it's not something that happens with the snap of the finger and then boom, you have the disorder. So it's happening slowly and gradually. So usually people with this disorder have impaired attention as well as alertness, also visual hallucinations, so they see things that are not really there, as well as motor impairment. Okay, so the next is the Parkinson's disease. Okay, so there's a wrong spelling here, forgive this one. Which is a degenerative brain disorder due to dopamine pathway damage. So the statistics for this one is that 1 out of 1,000 people are affected by this disorder, and the problem is that they would have motor problems with this, like tremors, posture, walking, and speech are noticeably um, affected. Like for example, with their speech, they would be speaking in a slurred way as if they are drunk. And then with the tremors, it would get so bad that they would look as almost as if that they are dancing usually. So in the latter years of Muhammad Ali, the famous boxer, as well as Michael J. Fox, a celebrity, an actor rather. They have Parkinson's disease, and you can see noticeably how they would be how they walk and how they speak. There is something that is not really normal with the way they walk and the way that they talk. Excuse. Okay, not all Parkinson's disease will develop dementia. There are some that develop dementia, but not all really will develop dementia later on in life. About 75% survive for 10 years or more after they are diagnosed with this disorder. And then this is a good number, for as long as the person is able to manage the condition well. Then we have next the HIV, neurocognitive disorder due to HIV infection. Now, HIV-1 can cause neurological impairments and dementia in some individuals. So, the features of those are the following: cognitive slowness, meaning to say they would not be able to do things as rapidly as before, like for example, calculate, make decisions. So that there is a there will be lags. They are still able to do it, but there are lags on how they do that. There are also impaired attention as well as forgetfulness. Apathy and social withdrawal is also seen with them, and this happens typically in the later stages of the disease. At present, it occurs in less than 10% of the individuals with HIV. Okay, now moving on to the Huntington's disease. This is a genetic autosomal dominant disorder. So this is caused by gene on chromosome 4. So they already have mark which gene is causing the disorder to happen. So this is manifested initially as involuntary limb movements, particularly called as chorea, which usually happens later on in life. This somewhere along 20% to 80% of the population display this neurocognitive disorder, and on the part of the dementia will happen, and it follows a subcortical pattern. Now, for this particular disorder, this is a neurocognitive disorder due to prion disease. Now, again, this is the disorder of proteins in the brain that reproduce and cause damage. So, the brain that they the brain, no, the protein that they are digesting is not good for them, because it basically attacks, or it basically causes the anomaly to happen on the brain. So there is no known treatment for this particular disorder, and it's often always fatal. And this one, if you're not a cannibal, definitely you will be safe from having this disorder, because this can be only acquired through cannibalism or accidental transmission. Like for example, uh, you had been contaminated during a blood transfusion with someone with the same disorder. Um, and this is affects about 1 out of 1 million persons. So this is quite rare, and this type of disorder is linked to mad cow disease. Now, for the substance or medication induced neurocognitive disorder, about 50% to 70% of chronic heavy alcohol users use some kind of cognitive impairment, and about 7% of those meet the criteria for neurocognitive disorder. And this is something that we see from older men who had a history of as heavy drinkers. So this is the result of prolonged drug use or substance use, especially in combination with poor diet. This may be caused by alcohol, sedative, hypnotic, anxiolytics, or other inhalant drugs. So we have just recently discussed this particular group of disorders. So I'm pretty sure you are still the effects of these substances to the body, particularly to the brain, are still quite fresh on your memory. For this disorder, the brain damage may be permanent because of the fact that the amount of substances used were quite a lot, and the person also did not even compensate with proper nutrition or poor or healthy diet for that substance use. So the symptoms may be similar with Alzheimer's and can include the following. So first is the memory impairment. They would have lapses in their memory. They would forget things. They would forget who they are at times, or whom they are talking to at times. Those things. Another would be aphasia, apraxia, and agnosia. So we have discussed this earlier. So failure to remember things, faces, among other things. And of course, the disturbed executive functioning, wherein they don't really have a good command of their decision making and judgment anymore. Okay, so for the causes of neurocognitive disorder, so let's have the Alzheimer's disease as an example. So the features of brain with Alzheimer's disease, they have neurofibrillary tangles or strand-like filaments, and then they also have amyloid plaques or gummy deposits between neuron. These are not normal inside the brain. There should be no deposits between neurons, that because it may interfere with how the neurons communicate with each other. Aside from that, they have also seen that the brains of Alzheimer's patients tend to atrophy. So just like the muscles, they can shrink. So just like what I've shown you earlier, a PET scan of someone with, was it dementia? I forgot. I might have this disorder. Wherein the volume comparing it with the normal brain, the volume of the brain is visibly smaller than the normal brain. Aside from that, there are multiple genes involved in the Alzheimer's disease. This can include the genes on chromosomes 21, 19, 14, and 12. For the chromosome 14, this one had been implicated with the early onset of Alzheimer's. Chromosome 19 had been implicated with the late onset of Alzheimer's. Now, for the deterministic genes, rare genes that inevitably lead to Alzheimer's, they have also detected that the beta amyloid precursor gene, which is presenilin 1 and presenilin 2 genes. Also, susceptibility genes are also marked. So uh, these are genes that are more likely but are not a certainty that the person will develop Alzheimer's later on. Okay, another example of susceptibility gene is the ApoE4 gene, which is located on chromosome 19. So, the one that is associated with the late onset Alzheimer's. So, among Alzheimer's patients, more prevalent in those who have a family history of disease. So, again, the biological component here is evident, particularly the family history of the disease. Aside from that, we also have the environment as a cause of the neurocognitive disorder. If you have already the genetic predisposition to that, the cognitive decline will likely happen more if you are in a very stressful environment. Okay, what about the psychosocial factors in the neurocognitive disorder? So this is also linked with high blood pressure, and although it cannot cause dementia directly, it can exacerbate the symptoms. So, and can also influence the onset and the course of the disease. So, like for example, if the person has heavy drug use or had prolonged drug use, like for example, alcohol, so those things that can be a precursor to the development of the neurocognitive disorder later on. The diet also, as well as exercises and stress. With exercise, I cannot stress this enough. We all need exercise, physical activity that is not related to walking and window shopping, exercise per se. Because when we do this physical activity, our brain is still active, although we're just doing it, even though we think that we're just going through the motions of the exercises or of the regimen. Specific areas of the brain are being exercised as well in order for us to execute that particular move or exercise. Now, cultural factors, the risks for certain condition vary by ethnicity and class. So there are things like that. Like for example, if the person is from is a Caucasian or from the eastern side of Asia, or East Asians like Japanese, Chinese, Koreans, they are prone to more stress, so they can develop the neurocognitive disorder related to stroke because of that kind of culture that they have. Other psychosocial factors that can affect the development of the disorder are as follows. The educational attainment, of course, the higher the education that you have, the higher the chances that you will be exposed to a lot of stress, specifically, and also developing a neurocognitive disorder, particularly the one that is related again to stroke. coping skills as well can be very very important in understanding this why the disorder like why disorders like this happen. The same with social support. Now, for the medical treatment of the disorder, there are few primary treatments. So, and most of them, these are not for the prevention per se, but rather these are more focused on slowing the progress of the disorder or the disease. So, it tries to stall the progression of deterioration. However, it cannot cure it. Now, for the future directions of the medical treatment, what they want to do, or what they have been doing in the research is the researching the glial cell derived neurotropic factor, as well as the stem cell, which we know that are only afforded by the rich, like Enrile, and they are seen to be very effective in slowing down the deterioration. And then, of course, there are medications like, for example, cholinterase, uh, cholinterase inhibitors, which brand name Aricept, Exelon, and Reminil, uh, which are drugs that help to target the neurocognitive deficits. However, despite of these medications, the long-term effects of these medications are not really seen as of yet. Okay, so what are some of the exploratory treatments? They have been, or other practitioners in the field had been recommending ginkgo biloba to improve the memory. However, the findings are not conclusive. Findings are mixed about this one. They're not really sure it if it's really helping with the memory, or if it's placebo or whatnot. So drugs to treat the associated symptoms, they use SSRIs for depression, as well as anxiety, and then antipsychotics for agitation. However, the problem with this one, these are not effective for a long time, and they are still testing vaccines for these types of disorders on genetically altered mice. Okay, now moving to the psychosocial treatment, the aim of this type of treatment is to enhance the lives of the patients as well as their families. So, and also they focus the psychosocial treatment, as you can see so far with all of the disorder, is it's not more on the preventive, but it's more on adapting. You have this type of disorder, yes, however we don't have any cure for it, so we'll try to help you out in terms of how to adapt and compensate for this disorder. They also do this in order to they also do this or use this to help them enhance memory enhancement devices, like for example memory wallets, which contains statements about one's life. Cognitive stimulation are also done in order to delay the onset of more severe symptoms, like for example cognitive exercises, so on. Now, for the caregivers, and these are the people, they can be family or they can be hired help. They are given instructions on how to handle problematic behavior specifically wandering, socially inappropriate behavior, aggressive or rebellious behavior, as well as the impact of care on their own health. So, caregivers are also undergoing a great deal of stress that may need mental health treatment. So, for mental health professionals, it's not that the focus is not only on the patients themselves but also on the caregivers, because they are the ones who have intact cognitive functions, so that most of the time they have to think of ways how to keep the patient safe, how to limit or to prevent the patient from doing things that may be harmful to them as well as to other people. Okay, so with the prevention, so the prevention is more on reducing the risk and not preventing the symptoms per se. So with the risk, the use of anti-inflammatory medications are also done. Control blood pressure, leading to active social life, and also cutting back on vices such as smoking and drinking. Other target of prevention efforts to increase safety behavior in order to reduce head trauma are reducing exposure to neurotoxins and use of drugs. So to summarize it all up, the cognitive disorders span a range of deficits. So we covered a lot, not just only Alzheimer's and dementia per se, but also neurocognitive disorders caused by medical conditions and substances. So, with the neurocognitive disorders, it affects attention, memory, language, as well as motor behavior. And this can, the cause can include the aging, medical condition, abnormal brain structures, the drug use of the person, as well as the environmental factors. Okay, and lastly, most result in progressive deterioration of functioning, particularly the cognitive functioning. And then in the treatment, there are few treatments to exist that will reverse the damage and deficits, but the progression of the disorder can be slowed down. So that's it for the discussion. So thank you so much, guys, for staying with me and being patient with all of my uploads. Good luck on your tests and good luck with your other case analysis. So we still have the second round of case analysis, which I will be giving to you after the exam is done. Okay, so thank you so much, guys, and fighting!